Dear colleagues, we shall start now with the joints of the upper limb. Joints of shoulder girdle are sternoclavicular joint and acromioclavicular joint. Sternum and clavicle together form the sternoclavicular joint. The articular surfaces are sternal end of clavicle and clavicular notch of sternum. Between the clavicle and sternum, we have articular disc which attach to the capsule, dividing the joint into two cavities. Articular capsule is strong and is reinforced by anterior and posterior ligaments. The rounded sternal end of clavicle articulates with the shallow socket at the superolateral angle of the manubrium sterni and the first costal cartilage. The medial end of clavicle rises higher than the manubrium, hence it poorly fits into its shallow socket. But a strong, thick articular disc of fibrocartilage attached superiorly to the clavicle and first costal cartilage inferiorly prevents the displacement of the medial end of the clavicle. The articular surface of clavicle is convex from above downwards and slightly concave from front to back. The articular surface of sternum is curved. Both articular surfaces are covered with fibrocartilage. The joint capsule is attached to the margins of the articular surfaces, including the periphery of the articular disc. The synovial membrane lies the internal surface of the fibrous joint capsule, extending to the edges of the articular disc. The sternoclavicular joint is a saddle type of the synovial joint. The ligaments of the sternoclavicular joint provide much of its stability. There are four major ligaments: the red one, anterior sternoclavicular ligament; the blue one, posterior sternoclavicular ligament; yellow, interclavicular ligament; and green, costoclavicular ligament. Anterior and posterior sternoclavicular ligaments strengthen the joint capsule anteriorly and posteriorly. The posterior ligament is weaker than the anterior ligament. Interclavicular ligament spans the gap between the sternal ends of each clavicle and reinforces the joint capsule superiorly. Costoclavicular ligament consists of two parts and bind at the first rib and cartilage inferiorly and to the anterior and posterior borders of the clavicle superiorly. It is a very strong ligament and is the main stabilizing force for the joint, resisting elevation of the pectoral girdle. The sternoclavicular and interclavicular ligaments can be considered to be thickenings of the joint capsule. The sternoclavicular joint allows the movements of the pectoral girdle. This joint is critical to the movement of the clavicle. Movements are elevation and depression, forward and backward, rotation and circumduction of the acromial end of the clavicle. Anterior dislocation are associated with a prominent and palpable medial clavicle, which can be fixed or mobile. Patients with posterior dislocation typically have more pain than anterior dislocation. Posterior dislocation can be associated with respiratory difficulties. The acromioclavicular joint consists of an articulation between the lateral end of the clavicle and the acromion of the scapula. The articular surfaces of the joint are lined with fibrocartilage. The joint cavity is divided by an articular disc. The joint capsule consists of a loose fibrous layer which encloses to the two articular surfaces. It also gives rise to the articular disc. The posterior aspect of the joint capsule is reinforced by fibers from the trapezius muscle. As will be expected of a synovial joint, the joint capsule is lined internally by a synovial membrane. This secretes synovial fluid into the cavity of the joint. It is a plain type of the synovial joint. There are three main ligaments that strengthen the acromioclavicular joint. Acromioclavicular ligament runs horizontally from the acromion to the lateral clavicle. It covers the joint capsule, reinforcing its superior aspect. Conoid ligament runs vertically from the coracoid process of the scapula to the conoid tubercle of the clavicle. Trapezoid ligament runs from the coracoid process of the scapula to the trapezoid line of the clavicle. The conoid and trapezoid ligaments are known as the coracoclavicular ligament. It is a very strong structure, effectively suspending the weight of the upper limb from the clavicle. A gliding movement takes place when the scapula rotates or when the clavicle is elevated or depressed. The acromioclavicular joint permits the rotation of acromion of scapula at the acromial end of the clavicle. These movements are associated with movements of scapula. Acromioclavicular joint injuries are characterized by damage to the acromioclavicular joint and surrounding structures. They are a common contact sports injury in young male athletes. The patient frequently reports a fall on the shoulder. On inspection, a high lateral clavicle can be seen compared to the uninjured side. Joints of the free upper limb are shoulder joint, elbow joint, wrist joint, and joints of the hand. Shoulder joint or glenohumeral joint is a joint between the head of the humerus and glenoid cavity of the scapula. The shoulder joint is the most movable joint of the body and consequently one of the least stable. It is the most common joint to dislocate and to undergo recurrent dislocations. The shoulder joint is a ball and socket type of synovial joint and is formed by articulation of large round head of humerus with a relatively shallow glenoid cavity of the scapula. The glenoid cavity is deepened slightly by the fibrocartilage ring called glenoid labrum. The thin fibrous layer of the joint capsule surrounds the glenohumeral joint. It is attached medially to the margins of the glenoid cavity beyond the glenoid labrum and laterally to the anatomical neck of the humerus, except inferiorly where it extends downwards 1.5 cm or more on the surgical neck of the humerus. Medially, the attachment extends beyond the supraglenoid tubercle, thus enclosing the long head of biceps brachii within the joint cavity. The synovial membrane lines the inner surface of the joint capsule and reflects from it to the glenoid labrum and humerus as far as the articular margin of the head. In this joint, we have one specific situation in the body. The tendon of the long head of the biceps passes through the joint and is enclosed in a tubular sheet of synovial membrane, which is continued around the tendon into the intertubercular groove as far as the surgical neck of the humerus. Please remember that inside the cavity we have tendon of long head of biceps which passes through the cavity to find supraglenoid tubercle for his attachment. The shoulder joint ligaments are coracohumeral ligament and glenohumeral ligaments. Coracohumeral ligament is a strong band of fibrous tissue that passes from the base of the coracoid process to the anterior aspect of the greater tubercle of the humerus. There are three glenohumeral ligaments in the anterior part of the fibrous capsule. These are called superior, middle, and inferior glenohumeral ligaments. Glenohumeral ligaments passes from the anterior margin of glenoid cavity to the anterior aspect of the greater and lesser tubercles of the humerus. A defect exists between superior and middle glenohumeral ligaments, which acquire importance in the anterior dislocation of the shoulder joint. I will repeat again that the shoulder joint is a ball and socket joint and is the most mobile joint in the body. The tremendous range of motion at this joint is the result of few external ligaments that present little limitation to movement and shallow, ovoid articular surfaces that make movements in all planes of space possible. Surrounding muscles and tendons play a more significant role in joint support than the joint structures. The capsular ligament is extremely lax, providing limited support to the joint. Blending with the capsule are the tendons of four muscles. Together, the capsule and tendons form the rotator cuff, which is the major support structure of the joint. The glenohumeral joint permits four groups of movements. First, we have flexion and extension. During flexion, the arms move forwards and medially, and during extension, it moves backwards and laterally. These movements take place parallel to the plane of glenoid cavity. Second, we have abduction and adduction. During abduction, the arm moves anterolaterally away from the trunk, and during adduction, the arms move posteromedially towards the trunk. Here we have abduction and now adduction. These movements occur at right angle to the plane of flexion and extension. The third, we have medial and lateral rotation. These movements are best demonstrated in mid-flexed elbow. In this position, the hand moves medially in medial rotation and laterally in lateral rotation. And finally, circumduction. The circumduction at glenohumeral joint is an orderly sequence of flexion, abduction, extension, and adduction, or the reverse. During this movement, the upper limb moves along a circle. The movements of shoulder joint occur in all the three planes and around all the three axes. Here we have flexion and extension, abduction and lateral rotation, abduction and adduction, and adduction and medial rotation. The abduction and adduction occur in frontal plane around the sagittal axis. The medial and lateral rotation occur in transverse plane around the vertical axis, and circumduction is really only a combination of all above movements. This is the case of dislocation of shoulder joint. A dislocated shoulder is an injury in which upper arm bone pops out of the cup-shaped socket that's part of shoulder blade. The shoulder is the body's most mobile joint, which makes it susceptible to dislocation. The elbow joint is a joint between the lower end of the humerus and upper ends of the radius and ulna. There are three articulations in the elbow region: humero-ulnar, between the trochlea of the humerus and trochlear notch of the ulna; humero-radial, between the capitulum of the humerus and the head of the radius; and superior or proximal radio-ulnar, between articular circumference of radius and radial notch of ulna. Joint capsule is a fibrous sac enclosing the joint cavity. The inner surface of the capsule is lined by the synovial membrane. Above, it is attached to the medial epicondyle, upper margins of the radial fossa, coronoid fossa, and olecranon fossa, and lateral epicondyle of the humerus. It encloses all the non-articular fossa at the lower end of the humerus. Below, it is attached to the anterior and medial margins of the coronoid process of ulna, upper margin of the annular ligament, and upper and medial margins of the olecranon process. To facilitate the movements of flexion and extension, the anterior and posterior aspects of the capsule are thinner than the sides. The inner surface of the joint capsule and non-articular bony parts inside the capsule are lined by synovial membrane. The synovial membrane forms a fold between humeroradial and humerulnar parts, which contains an extrasynovial fat. We have four major ligaments of elbow joint: annular ligament, radial and ulnar collateral ligament, and quadrate ligament. Annular ligament is a strong fibrous band which encircles the head of the radius and holds it against the radial notch of ulna. Medially, the annular ligament is attached to the margins of the radial notch of ulna. The upper margin of the ligament is continuous with the capsule, and its lower part becomes narrow and embraces the neck of radius. The inner surface of annular ligament is covered by a thin layer of cartilage. Laterally it blends with the radial collateral ligament. Radial collateral ligament attached to lateral epicondyle of humerus and annular ligament of radius. Ulnar collateral ligament attached to medial epicondyle of humerus and medial border of trochlear notch of ulna. Quadrate ligament is thin fibrous ligament which extends from neck of radius to the upper part of ulna just below the radial notch. The elbow joint permits two groups of movements: flexion and extension, and supination and pronation. The movements of humero-ulnar and humero-radial joints are flexion and extension. Humero-ulnar joint is hinge joint and humero-radial joint is spheroid joint. Here we have flexion and extension in humero-ulnar and humero-radial joint together. The foot is picked up in pronation and put in mouth in supination. In supination, the radius and ulna lie parallel to each other. In pronation, there is rotation of lower end of radius along with articular disc on the head of ulna. As a result, the lower end of radius crosses in front of the lower end of the ulna. Simultaneously, the head of radius rotates within the fibro-osseous ring formed by the annular ligament and the radial notch of the ulna. The proximal or superior radio-ulnar joint is pivot joint. Nursemaid's elbow or pulled elbow is subluxation of head of the radius and occurs in preschool children when the forearm is suddenly pulled in pronation. The head of the radius comes out of annular ligament and the elbow is kept slightly flexed and pronated. An attempt to supinate the forearm causes pain. Here is the case of elbow injury, sports injury. Look at the right elbow. Now look at the position of the right elbow here and here. What do you think? What is the diagnosis? The diagnosis is elbow dislocation. The elbow dislocation is the second most common large joint dislocation in adults and the most common in children. The radius and ulna form two joints between them, one at their upper ends and one at their lower ends. They are called superior or proximal and inferior or distal radio-ulnar joints. Both these joints are synovial joints of pivot variety. They are permitting only rotation. The shafts of the radius and ulna are also connected to each other by interosseous membrane. Hand joints are radial carpal joint, medial carpal joint, carpometacarpal joint, metacarpophalangeal joint, and interphalangeal joint. The wrist joint, also known as the radiocarpal joint, is a synovial joint in the upper limb, marking the area of transition between the forearm and the hand. The wrist joint is an ellipsoid variety between lower end of radius and carpus. The wrist joint is formed by distally the proximal row of the carpal bone, except the pisiform, proximally the distal end of the radius and the articular disc. The ulna is not part of the wrist joint. It articulates with the radius just proximal to the wrist joint at the distal radio-ulnar joint. It is prevented from articulating with the carpal bones by the articular disc which lies over the superior surface of the ulna. Together, the carpal bones forms a convex surface which articulates with the concave surface of the radius and articular disc. Joint capsule consists of two layers. The fibrous outer layer attaches to the radius, ulna, and the proximal row of the carpal bones. The internal layer is comprised of a synovial membrane, secreting synovial fluid which lubricates the joint. There are 4 ligaments in the wrist joint, one for each side of the joint. Palmar radiocarpal ligament is found on the palmar or anterior side of the hand. It passes from the radius to both rows of carpal bones. Its function, apart from increasing stability, is to ensure that the hand follows the forearm during supination. Dorsal radiocarpal ligament is found on the dorsum or posterior side of the hand. It passes from the radius to both rows of carpal bones. It contributes to the stability of the wrist, but also ensures that the hand follows the forearm during pronation. Ulnar collateral ligament runs from the ulnar styloid process to the triquetrum and pisiform. Works in union with the other collateral ligament to prevent excessive lateral joint displacement. Radial collateral ligament runs from the radial styloid process to the scaphoid and trapezium. Works in union with the other collateral ligament to prevent excessive lateral joint displacement. The wrist joint permits the following movements: flexion, extension, abduction, adduction, and circumduction. Flexion and extension occur along the transverse axis, and abduction and adduction occur along the anteroposterior axis. Joints between the carpal bones are synovial joints which interconnect the carpal bones. They are gliding joints. They include the 3 following joints. First, we have joints between the carpal bones of the proximal row. Second, we have joints between the carpal bones of the distal row. And third, we have midcarpal joints between the proximal and distal rows of the carpal bones. Blue line represent position of midcarpal joints. Bases of the metacarpal bones articulate with the distal row of the carpal bones and form carpometacarpal joints. The carpometacarpal joints are plain type of synovial joints, except for the carpometacarpal joint of the thumb, which is a saddled joint. The distal surfaces of the carpus of distal row articulate with the bases of the metacarpus. The blue line represents position of carpometacarpal joints. I will repeat again that the carpometacarpal joint of the thumb is saddle joint. Articular surface of trapezium articulate with the articular surface of base of the first metacarpal bone. Functionally, first metacarpal joint is the most important carpometacarpal joint. Metacarpophalangeal joints are synovial joints of a little bit ellipsoid or condylar variety. Articular surfaces are formed by heads of metacarpals and bases of proximal phalanges. Movements are flexion and extension, abduction and adduction, circumduction, and limited rotation. The phalanges articulate with each other and form interphalangeal joints. Both proximal and distal interphalangeal joints are synovial joints of hinge variety. On left picture, you can see in sagittal plain finger and metacarpophalangeal joint, proximal interphalangeal joint, and distal interphalangeal joint. In right picture, We can see a lot of ligaments of the finger joints. You can see the medial and lateral collateral ligaments and palmar ligaments. These ligaments protect the joint capsule. Interphalangeal joints movements are as follows: flexion and extension, abduction and adduction, opposition and circumduction. Hand injuries are common and can involve a variety of structures such as the skin, tendons, nerves, blood vessels, bones, and joints. The risk of finger, hand, or wrist injury is higher in contact sports. Dear students, if you have any kind of questions and suggestions, you can send me email.